Okay. Perfect. So, welcome everybody. It's my pleasure to introduce you today, Professor Lisa Bortolotti, who is a professor of philosophy at the University of Birmingham, working in the philosophy of the cognitive sciences.
Yeah. Sure.
She's investigator in two externally funded projects, one on agency in youth mental health and one on epistemic injustice in healthcare. She's also the editor-in-chief of Philosophical Psychology. And I would like to mention just her last books. Her very last book is Why Delusions Matter, dated 2023. And her next book is Epistemic Justice in Mental Healthcare, an open access edited collection in the Palgrave Pivot series, which will be published next month, so very fresh. And today, she will give a talk for us entitled Epistemically Just Interactions Are Good Medicine. Looking forward to listen to you. Thanks a lot for being here.
Thank you very much, Valeria and Francesca, for the invitation. I'm very, very happy to be at PhenoLab. I just want to say I'm not a phenomenologist, so be kind to me in question time if there are themes that I'm touching on where I'm not providing a satisfactory answer from that perspective. What I'm going to do today is talk about something fairly new. So it's a paper I'm working on. I've presented it a few times already, but I'm kind of revising it. So if you've got any feedback, I would be extremely grateful for your thoughts. And it's basically part of a recent project that I'm involved in and that Valeria mentioned on epistemic injustice in healthcare. And the part of the project that I'm interested in focuses on mental health in particular. So we're thinking about how to apply the notion of epistemic injustice to this domain and what are the kind of challenges that we've got. So what I'm going to do today is briefly touch on what epistemic injustice is. It may be familiar to many of you, but maybe not all of you. It's a notion that comes from the intersection between epistemology and ethics and from a book by Miranda Fricker where she introduces the notion. And it has been really taken up in all aspects of philosophy. So people are really discussing this notion and its applications very widely. But the notion of epistemic injustice I want to focus on today is what Jose Medina talks about when he talks about agential epistemic injustice, which is quite specific, and I will show you some examples outside healthcare where this notion can be applied. And then finally, I will apply it to the case of mental health care and kind of offering you some reasons to believe that agential epistemic injustice is actually quite useful notion to have in the context of mental health care. I'm also going to suggest that contrary to some criticism that have been made to the application of epistemic injustice in psychiatry, if we do not try and aim at having clinical interactions, so interactions between practitioners and patients that are epistemically just, then we might not be able to meet the medical goals of the interaction. So not only we may be doing something bad in a kind of moral or ethical sense because we are wronging the patient in their rights as a knower, as someone who can contribute to knowledge, but actually we are making it more difficult for the patient to achieve better health outcomes. So that's the claim. Let me start with the notion of epistemic injustice, which is simply a case where harm is inflicted on a person in their capacity as a knower. What that means is that we are all agents and epistemic agents. We are interested in getting knowledge about things. We're interested in sharing knowledge with others, so kind of exchanging information. And if there is a negative stereotype that is associated to our identity, which prevents other people from giving us authority and credibility when we're sharing knowledge, then what happens is that we may be harmed, and the harm can be thought about or described in terms of epistemic injustice. So when Miranda Fricker first developed her account of epistemic injustice, what she did was focusing on cases of racism and sexism mostly. So those were cases where, for instance, a woman's contribution to a certain project would be dismissed just because she was a woman, and women were thought not to be able to contribute to that project. But our idea in the project that we are working on now, which is called EPIC, is that indeed we can apply that to other contexts such as healthcare. So before I'm going to describe a little bit what the project is like and what we aim to do. I just want to show you a 90 seconds video, if that works. I'm not sure if the technology smiles on us today. That we created to introduce people who are new to epistemology or ethics to the notion of epistemic injustice. So it's something that we imagine doctors may be watching to understand, for instance, what the notion of epistemic injustice is. And it's built around the idea of the Aesop fable. So there are kind of animal characters interacting. And I'm just going to show it to you, and then we'll say a little bit about it afterwards, if that works.
The fawn and the mountain lion. When is dismissing another's report an act of injustice?
It's late. Let's go to the lake to get some water before it gets dark.
Wow, I would love to gobble that up. Oh no, never mind the acorn. Mummy, Daddy, I just saw a huge mountain lion behind the bushes. We have to go. It is not safe here.
If there was a mountain lion behind the bushes, I would have heard the steps. You must have imagined it.
I am not sure we should stay. Shouldn't we listen to Little Fawn and get back to the herd? He has never lied to us before.
Calm down. Young ones don't distinguish reality from imagination, and they always try to draw attention to themselves. Why don't you get some water, Little Fawn? You will be thirsty otherwise. This water is delicious, so fresh.
Are you okay? We sometimes dismiss a report when we don't trust the speaker due to some negative stereotype. But in dismissing what the speaker has to say, we pay a high price. We reject information that can be valuable to us. You are right, Wise Owl. In our herd, females and fawns are never listened to, but Little Fawn recognizes a mountain lion when he sees one. To dismiss him is not just risky, it is an injustice. He should not be silenced when he has something to say.
So one thing to notice about the story is that although it's very simple and of course very short, it captures some basic ideas about epistemic injustice. One idea is that although we recognize epistemic injustice in interpersonal relationships, like parent, child, or teacher, student, or employer, employee, doctor, patient, epistemic injustice can actually be amplified in institutions, can be a cultural problem. So what Doe says at the end, that the opinion of females and young ones is never heard in the dear society, which is a very hierarchical society, means that it's not an isolated problem, it's a problem that repeats itself. The other thing that we want to really point to in this particular video was the idea that when epistemic injustice happens, it's characterized as harm, as a wrong for the person who is being silenced or dismissed. But indeed, very often, the person who is missing out is also the person who is listening or who is supposed to be listening and is instead dismissing. Because what happens is that there is a certain type of information that is available only if the testimony of the person who is speaking is taken seriously. If that information is not there, then there could be problems and risks, as in the story. So that was just an introduction to the notion of epistemic injustice. Our project has 6 case studies in healthcare. Some of them are in mental health care, for instance, dementia, psychosis, and severe depression in the context of terminal cancer. And what we are looking at is really testing the notion of epistemic injustice, asking ourselves, is it a useful framework in order to understand what is happening in some patient-doctor relationships? And in my particular view, like I'm mostly interested in mental health and in those conditions that are considered to be severe, like schizophrenia, for instance, or dementia. The most apt notion of epistemic injustice is the notion of agential epistemic injustice. And if we think about where it originates, it's an idea by Jose Medina, who wants to kind of elaborate on Miranda Flicker's work. And agential epistemic injustice is not necessarily silencing someone. Very often, agential epistemic injustice happens when we ask someone to contribute, but then the way in which we receive that contribution is of a particular kind. And so, for instance, the contribution may be reconstrued in a different way from the way in which it was offered. It may be manipulated or distorted. So let me offer a couple of examples so that it's easier to think about this particular notion and how it applies to everyday life. If you are in a philosophy lecture and the teacher is explaining something, and then there is a student from a marginalized group raising their hand, and they ask a question. Now, it may be that in the student's intention, that was an objection, right? They wanted to raise a concern about what the teacher was saying. But the teacher interprets that particular question as a request for clarification. Why? Well, in the example by Hookway, what happens is that the teacher doesn't think that the student is competent enough to provide an objection to their argument, and so they interpret it as a request for clarification. Another case is harmful inclusion. So these are cases where the contributions of members of marginalized groups are solicited, but when they actually do make that contribution, that is inserted into a framework that distorts the contribution itself. So an example by Pohaus is, for instance, think about a category that is underrepresented, like, I don't know, people of color in a philosophy department in the UK. That would be a good example. Now, if a university in the UK were to say, oh, we want to know more about what we can do to avoid discrimination and increase inclusion and diversity, we are going to ask the members of staff or people of color, what are the problems that they encounter. But then whenever they offer some evidence suggesting that there are issues that are affecting their life in the department, they are asked to provide more and more proof of that, and in a way in which actually proof is very difficult to be provided. So what happens is that there is a very intensive labor on behalf of this marginalized group, which does not ultimately result into information that can be used meaningfully to improve the situation. And the last case is probably the most dramatic, given the examples, is the idea of extracted testimony. So the contribution of the speaker is valued only when the agency of the speaker is annihilated. So the classic example by Kivelson is the Salem witch trials. So if someone who was thought to be a witch were to provide a spontaneous testimony, that wouldn't be believed. But if they were providing this testimony under torture, then you'd be believed. The idea is that they could tell the truth, they could say something valuable for others, only when they didn't have any agency. So when they were forced to do that, coerced to do that on or under torture. And there are other cases like similar to that. For instance, police forcing confession from people from marginalized groups for crimes that they haven't committed, right? So when they say, no, I haven't done it, they're not believed. But when they are under all this pressure from the police and ultimately they say what the police wants them to say, then they are believed. Now, I think these are really interesting cases because there are cases where there is no silencing, and yet, you know, we can identify some elements of epistemic injustice. But what really interests me about these cases is that not only we're doing something bad to the person whose testimony is distorted, but we are actually making the exchange less likely to meet the actual goals that the exchange is supposed to have. So we think that there is a good philosophical discussion if the interesting objections are considered reflected upon. But if there is a philosophical discussion where the objections are not addressed, that is not a good philosophical discussion, right? So the very goals of the philosophical discussions are not met. If we want to make progress with inclusion, it's no point in, trying to get people to say the things that you want them to say because maybe you've got an easy fix to provide. Well, because that is not going to address the problem of diversity and inclusion. And similarly, if what you're interested in is the truth or justice, then forced confession will not get you closer to truth or justice. So my hypothesis is that this is true in the healthcare context as well, in particular mental health care. So for some interactions to be successful, speakers need to be able to make a genuine contribution to the interaction. If the goal of the clinical interaction is to improve outcomes for people who are struggling with their health problems, then epistemically unjust practices are an obstacle to achieving that goal. And that is what I'm going to try and show in the rest of the talk. I think the notion of agential epistemic injustice is extremely fitting for certain types of severe mental health issues, because in the case of, let's say, schizophrenia or dementia, the assumption is that if we are diagnosed with one of those conditions, our capacity to produce and share knowledge or to behave as an epistemic agent are entirely compromised, right? And how do we know that? Well, first of all, we could consider the kind of stigma that is associated with those conditions in our society, but also reflect on the fact that there is a certain type of disengagement from people who have those conditions, or pervasive forms of exclusion or coercion, even in healthcare, that would not be acceptable if the capacities of those people were considered to be intact. Right? So it's because they are thought not to be able to contribute meaningfully to certain types of epistemic projects that their voice is not listened to. And I'm going to show you another very short video, again, only 90 seconds. And this is a very interesting story. So it has been scripted by a group of young people called the Voice Collective. And these are young people from 16 to 25 who hear voices and have unusual beliefs. And they meet regularly to support each other. And in a series of 7 workshops, we worked together with them to ask them what were the stereotypes that were associated with hearing voices, and whether these stereotypes, according to them, were harmful, whether they were experiencing some harm due to those stereotypes. And they come up with the idea of having a video where the 3 main characters embody the key stereotypes for young people who hear voices, which is being dangerous, being incompetent, and being so different that you cannot be included in other people's activities. So this is what they came up with.
The wolf, the snake, and the butterfly. Challenging assumptions about young people who hear voices.
Wolf, what are you doing here? Hasn't your pack moved on last night?
They left at sunset, without me. With my limp, they think I'll be a burden.
Butterfly, what are you doing in the clearing? Isn't the poppy field more your scene?
Well, I'm tired of the teasing. Bee keeps saying that I don't pull my weight.
What nonsense. Without your constant wandering, there would be hardly any flowers.
Sure, I'm a good pollinator now. But Bee thought I was useless as a caterpillar, eating all day long, and still thinks so.
Stereotypes are hard to overcome. I'm really gentle, but humans run scared when they see me and even beat me with a stick if they get a chance.
Snakes and wolves win no popularity contest. Aren't we always the villains in fairy tales?
Young people who hear voices have similar experiences to ours.
We're often isolated because we're different.
We're considered dangerous even by those who are there to support us.
We are treated as if we can't achieve anything.
When others find us useless or dangerous or exclude us because we're different, we experience harm, and it's harder for us to do the things that we value.
But we do have a lot to offer.
Okay, so in this video, again, you see the harmful stereotypes, and all those situations that you see in the bubbles are actually situations that really happen to the young people in the group, situations that they shared with us. And it's quite interesting because some of them are situations where we would say there is an epistemic injustice. So you're not allowed to contribute because people associate with you a certain stereotype that might not be actually an accurate description of whether you can contribute to that epistemic project. So mental health patients face some of the following situations, and you've got some citations there if you want to look at the empirical literature on this. They're being devalued as testifiers in clinical encounters. They often experience clinical communication as a confrontation because everything they say is challenged. They're having their testimonies edited so that they fit in the framework of their practitioners, and they're being excluded from key aspects of their clinical encounter, such as the choice of the most appropriate treatment option. So they don't participate in the selection of, the choice of support or the choice of medication, with which normally the clinical encounter ends. And now I want to show you some examples from our own work. So we have been engaged since the pandemic in what we call the agency projects, which are projects funded by UKRI on youth mental health, where I'm the only philosopher. So we've got psychologists, sociologists, psychiatrists, and young people with lived experience of mental health care as researchers. What we've been doing is analyzing conversations that have been recorded between young people accessing emergency services in the UK, mental health emergency services, and practitioners. And what happened is that, we have transcripts of those interactions, we've got videos, and then the people in those encounters, so the young patients were interviewed immediately after the encounter and sometime afterwards, so that they could actually tell us what they thought about the encounter, whether it was successful from their own point of view. I'm going to start with the case of Patrick. He's a young man who is referred to mental health emergency services from university counselors, and is asked at the beginning of the clinical encounter whether he feels, how he feels, because he was told to go to emergency services due to suicidal thoughts. And he describes himself as miserable and suicidal. So by the way, in the next few slides, I will be talking about self-harm, suicide, and depression. So if this is something you prefer not to hear, that is what is going to happen in the next few slides. So this is the transcript of the interaction between Patrick and the healthcare professional and the emergency services. So I feel like miserable kind of sums it up. And yet in your face, when you're speaking, you've got a variation, haven't you, of your expression, and you smile and things like that. So you have time when you clearly aren't miserable, you're sort of enjoying things. You're able to give the impression that you're enjoying things. So what plans did you have if you hadn't? Oh, well, I've got a few events on because I'm part of rugby, skiing, and tennis, and they were all putting events on tonight. I couldn't go to. I see. So could we safely say, that you wouldn't end your life or done something that would have, what, tonight? No, I wouldn't have ended it tonight. You wouldn't. Okay. So maybe there was a bit of miscommunication because they brought you here saying you were suicidal. No, I am, but you are? I feel I can. I mean, I haven't done it yet. So in this interaction, this is a very small extract from a much longer interaction. But we can see a number of behaviors that we have seen in a lot of the other interactions as well. Not all of them, of course. Some interactions are much more successful than this one. But these were analyzed using the method of conversation analysis, which is a method in sociology and psychology where people look at the pauses in the conversation, so at the actual script, but also the nonverbal cues. That's why the video is important, but we cannot show it online. So whether the person, for instance, makes eye contact, what the posture is, whether there is eyes rolling or whatever. So everything is considered. And what people have noticed doing this analysis is that the more you are challenged when you are presenting information, the less you engage. And you see this with Patrick, that after having received 2 or 3 challenges, is just kind of nodding and saying, rather than offering more information. And clearly Patrick is challenged. So the practitioner suggests that it doesn't look miserable, and also that because he had plans to meet his friends that night, he couldn't have had suicidal thoughts. So clearly here, there is no silencing. Patrick gets to talk about how he feels, at least at the beginning, and he's asked about his mood and his intentions. But there is no attempt by the practitioner to explore why Patrick describes himself as miserable and why he says he has suicidal thoughts. There is no attempt by the practitioner to try and find out what the experience of Patrick is, but there is a lot of kind of redescribing and reinterpreting what Patrick is saying about himself. To the point that we get to a passage where the attempt that Patrick made at seeking help, encouraged by university counselors, is actually being delegitimized. So the practitioner says, maybe there was a bit of miscommunication, like you're not really suicidal enough to be seeing emergency services. And at the end of the interaction, what the decision making is reflects this kind of perspective of the practitioner, because Patrick is not offered any particular support apart from invitation to visit a self-help website and the encouragement to continue accessing university counseling. Let's see another example. Here we've got Sasha, a young woman diagnosed with OCD, who mostly seems worried about a pattern that has changed in her eating behavior. And she claims to have lost a lot of weight and being quite close to being underweight at the time of the interaction. Because my obsessive behaviors have been getting worse and worse as well, they've now kind of spread into areas of my life, like eating. Yeah, Steve said that he was really concerned about the weight that I've lost so rapidly. And I can feel my heart slowing down, and I can feel the physical symptoms from it. And in terms of your understanding, what's your diagnosis, Sasha? OCD and anxiety, I think. Okay. And that for you, it makes sense, does it? Yes. The only thing that doesn't make sense is why I'm feeling unable to eat and restricting what I'm eating. Okay. Having kind of unpleasant thoughts about my body shape, and okay, that. Okay. And I assume you're really trying eating, as you're trying to give yourself permission to enjoy food, whatever. Because I guess you're quite slim, and if you're worried about losing more weight, now is not the time to start thinking, well, I shouldn't have any custard, or I shouldn't have any. So you're trying. Are you trying? Just have what you fancy when you could eat it. Again, it's easier said than done, but whatever it is, it's not letting me. It's not what, sorry? It's not letting me. Right, okay. Like I haven't eaten anything today, and I've barely eaten anything since Monday. Just, okay, yeah, it's got out of control. Okay. So you see here almost the opposite pattern. So here, whenever Sasha complains about or claims that she's concerned about her eating, the practitioner gives minimal engagement, so or nodding, but there is no attempt to, again, explore or elaborate what the experience is. And the most striking thing is the difference in the language that the practitioner and the young person uses when they describe the eating problem, right? So clearly, Sasha describes it as something that she cannot control. I'm unable to do it. It's out of control. It's not letting me. Whereas the practitioner brings everything back to the diagnostic level of OCD and doesn't give the eating disorder a lot of serious concern or serious thought, and describes it as something, the fact that she's not eating, as something that can be feasibly managed. Indeed, towards the end of the interaction, the practitioner suggests to Sasha that she should ask her boyfriend to sit with her at meal times, a reminder to eat. So the implication is that the problem is not a serious one, and no specialist support is offered to Sasha at this stage. So why am I presenting you with these scenarios, which are very kind of difficult, distressing as well to think about? Well, because I think that there may be a case of potential epistemic injustice here, because we see the young people participating in the exchange, but their participation is challenged almost constantly, reconstrued according to the practitioner's own understanding and interpretation of the situation. My way of diagnosing this is to say that Patrick and Sasha's contributions are not seen as contributions of a competent agent, are not taken seriously in that particular sense. So when they make statements that support the practitioner view, then those statements are taken on and integrated in a narrative explanation of the situation. But when the statements are in tension with the practitioner's view, they're challenged and undermined. And like the case of misinterpreted contribution in the education setting, the contributor injustice, or the false confessions in the witch trials, there is a lot of verbal pressure exerted by rephrasing, repetition, and close questioning. To the point that the style of questioning is almost forensic. And by that I mean that the practitioner tries to identify some inconsistencies in the patient's spontaneous reports. So you say you're miserable, but you don't look miserable. Which one is it? Now, what I'm going to try and say is that if we make these kind of interactions more epistemically just, we don't not only do something nice for people like Sasha and Patrick who feel like they're listened and understood, but we also make the interaction more useful in medical terms. We enable the interaction to fulfill the goals that that particular interaction is supposed to have. And why am I making this argument now? Well, because there is a lot of pushback against the idea of applying the notion of epistemic injustice to psychiatry. And most famously last year, Caius and colleagues published a paper in The Lancet arguing that epistemic injustice should not be applied to psychiatry, and it is harmful when it is applied to psychiatry, because practitioners cannot always believe what people seeking support say, and because the demands of epistemic justice may be clinically unhelpful. So I have lots to say about this, but I'm not going to address the first concern about credulity. I don't think epistemic justice is about believing what people have to say. That's something else. But I'm just going to focus on the second objection and claim that an epistemically unjust interaction is unsuccessful when measured against the key goals that an interaction of that type is supposed to achieve. And here, looking a little bit at the literature on what clinical interactions are supposed to be like, I've come up with 3 goals. And of course, in question time, you can challenge them if you don't think they are reasonable goals for a clinical interactions. Understanding the nature of the problem that the person is seeking support for, identifying the best means of support for the person experiencing the problem, and enabling the person to use the previously identified means of support to address the problem. So I think those are kind of general goals that a clinical interaction should have. And I think that the cases of epistemic injustice that may be kind of represented, exemplified by the interactions that we have read about, may be an obstacle to achieving those goals. The first argument is kind of a general knowledge exchange argument. It's quite intuitive. If we want a genuine exchange of information between the healthcare professional and the person seeking support, we want to be able to get the person seeking support to describe what the problem is. And this is especially important in the case of mental health, because in the case of mental health, often the symptoms are not something that can be just measured with some kind of objective medical tests, but it's the kind of thing that people need to talk about. They need to talk about what they see, what they think about, how their life is affected by their thoughts and their experiences. So the shared knowledge, of course, that is available to the practitioner if the person seeking support shares this information fits into a process that enables the practitioner to identify what the problem is. Very often this ends up being a diagnosis, right? It doesn't need to be, but a diagnostic label is often where these kind of interactions are going. And this, of course, impacts on the choice of support that the practitioner offers to the patient. So the claim is that agential epistemic injustice may prevent a genuine exchange of information because the contribution of the patient is distorted and manipulated. And so there is information lacking, the information that the practitioner will need to be able to come up with the best ways of supporting the patient. And this might result in premature labeling. So in providing a diagnostic label that doesn't really fit the person's experiences, or a sort of label conservatism that we saw in Sasha's example. If someone presents with, medical records that suggest OCD, then OCD is the problem. We don't open up to the possibility that there may be additional problems or problems that are more pressing for the patient. So suggestions for further support and treatment are of course based on partial and distorted information if we've got an epistemically unjust interaction, and the goals of understanding the nature of the problem and identifying the best means of support may be less likely to be met in those cases. Now, as I mentioned in the study on which this example are based, what happened is that the people accessing emergency services were also interviewed immediately after the encounter and later on. What happened then to Patrick and Sasha? As Bergen and colleagues say, over the next 3 months after the interaction, Patrick returned to emergency services twice, once for suicidal ideation and once for pharmaceutical overdose with suicidal intent. So Patrick did attempt to terminate his life. In his 3-month post-visit interview, Patrick reported that he would not have gone to the emergency services again because he was unhappy about the interaction that he had, but was brought back there by university counseling services. Sasha, as we know, did not receive a referral for specialist eating disorder services, but she was very closely supported by her family, and her parents managed to get specialist support for her, and she began treatment with an eating disorder specialist 3 months after the initial access to emergency services. By then, she had lost a substantial amount of weight, and she reported, "I did get the impression that some people weren't taking me seriously because I still look vaguely normal. I've lost even more weight since then, so kind of firmly within the anorexic range. So I think I don't know, maybe if I'd been able to access the help sooner, then you'd not have got to that stage." Now, nobody can guess what the future will be like, and we cannot certainly blame practitioners for not offering support that might not be available for them to offer. But I think the key point here is that neither Patrick nor Sasha felt that they were listened to, felt that they were taken seriously, independent of what type of support they were offered. And I think that's important for a second part of my argument, the motivation argument. Not only the patient needs to know what's going wrong, or what's going on with them. Doesn't necessarily need to be something wrong, but what's going on with them and how this can be addressed. They need to be made to feel that they can address it, that they can contribute to their health journey improving with the support that the healthcare professionals can give. But in order to do that, they need to feel like agents. They need to feel like it is in their power to do at least a little bit to make a contribution. Now, we know from the psychological literature on optimism bias and on hope theory that our capacity to feel the motivation to contribute to things going better for us is very much dependent on whether we feel we are helpless or not, whether we feel like agents. And this is a cognitive component, like perceiving ourselves as capable of pursuing a goal, like better health, but also a motivational component, right? Feeling that we've got the capacity to face difficulties that may initially prevent us from reaching that goal. The case of mental health, especially in young people whose identity is still very much malleable and in transition in this adolescent stage, is that already there is a threat to their sense of agency, because a lot of the mental health conditions that we have been looking at are conditions where the world feels more unpredictable for people, social interactions are more difficult, and as a result, people feel that they don't have control, that they lack control over their lives, and they lack control over what is happening to them. Think about Sasha saying that she can't make herself. And so what happens in these cases is that they are excluded from social interactions, going to be perceived as dangerous or incompetent, as we saw in the video that we did together with the Voice Collective. But in some situations, the clinical encounter can increase this sense of disempowerment. So they already feel helpless, but the clinical encounter can reinforce this idea that their voice doesn't count, that their experience is not worth being considered, that they sought help, but they shouldn't have sought help because they are not ill enough to get the support that they're looking for. And that is the problem, right? Independent of what support can be given, whether the person can feel like an agent, at least in that context, an agent who receives support, of course, not an agent who is responsible for everything that is happening to them. And this seems to be quite a general problem with mental health interactions. And indeed, in other areas, for instance, where people are studying interactions with people with dementia, similar words as the words that have been used for young people with psychosis or young people with depression and self-harm and suicidal thoughts are used. So the idea that these clinical encounters are infantilizing and dehumanizing. They treat the person needing support as someone who is not competent, even when they're describing how they feel, right? Whether they're miserable or not, whether they can eat or not. So just to conclude the motivation argument, I think the epistemically unjust interactions interfere with the last goal that we considered, which is the idea that the interaction needs to enable the patient to feel that they contribute positively to restoring or improving their health. So let me just conclude. If healthcare practitioners do not take patients' contributions at face value and explore their significance with something like curiosity and empathy, and these are the words that were used by the researchers with lived experience that contributed to our project. Very often they said, it doesn't matter how much time I get to talk to the practitioner. It doesn't matter whether they can offer support for me or not, but I want them to be curious about what's happening to me. Whatever medical condition I've got means for me, how it affects my life, rather than just being a label, someone with depression or someone with suicidal thoughts. So unless that happens, there is no shared knowledge on which to base either the diagnosis or the selection of adequate means of support, considering, of course, that someone's diagnosis can change over time, especially in youth when things are so dynamic. And if healthcare practitioners do not acknowledge that people seeking support are agents with a valuable perspective to share and with the capacity to contribute to positive change, and participate in decision-making, again, not making all the decisions, but being asked about their previous experiences, their preferences, and so on. People's sense of agency may be threatened not just by the mental health crisis, but also by the nature of the healthcare interactions that they experience. So the idea is that we want to make it better, we don't want to make it worse. And these kind of epistemically unjust interactions may turn out to be threats to the sense of agency of the young people. And, this is not the whole story. Of course, in our project, we saw a lot of interactions that were much more successful. And those interactions were exactly interactions where the practitioner asked questions about people's experiences. when you say that you feel like this, what do you think is due to, or, you know, how do you feel? Can you offer an example of a time that you felt in this way? And when they were coming up with possible ideas for therapy, the question was, have you tried grief counseling before? Did it work for you in the past? So again, you've got here the idea that there can be some kind of negotiation, some kind of collaboration, where the patient is not just passively receiving the practitioner's wisdom, but actually contributing with their knowledge. This idea that there may be epistemic injustice in these kind of interactions, I think is really important to think about in terms of the patient's compliance as well. It's much more likely that someone will follow the advice of healthcare professionals and seek further support when it is needed, or comply with medication if medication is prescribed, if there is a certain type of trust with the practitioner and the feeling that the practitioner has actually been listening to what is happening to us. So whereas in other contexts, we may feel that this is not so important. I think in mental health care interactions, this becomes quite center stage. Agential epistemic injustice prevents speakers from making a genuine epistemic contribution to the interaction and compromises the fulfillment of those goals that depend on such contribution. Thank you very much.
Thanks a lot for this amazing talk. And we can please stop the recording process. Thank you. So we can open up the discussion. So if someone has some remarks or question, please raise your hand or write them down in the chat. Don't know who wants to start. I can start actually, because yeah, a lot of thoughts came into my mind. So I do work mainly on neurodivergence and on autism in particular, and I do think that the topic of the epistemic injustice relies a lot on has a lot to do with the neurodivergent field. I think that neurodivergent people are very, very often the victims of epistemic injustice because they are not taught to make a lot of things or to be able to contribute to shared goals and so on and so forth. And in particular, you touched the topic of the labeling of the diagnosis, and I think that this concerns a lot autistic girls, because usually there are a lot of data about it. Autistic girls express autism in a different way. They are better in camouflaging and so on and so forth. So it seems that they are often diagnosed with eating disorders because, okay, you are a girl, okay, you suffer a little bit from social isolation, so okay, it's probably eating disorder. And they do struggle a lot for their whole life in order to have a proper diagnosis and accordingly proper support and also inclusion processes and so on and so forth. So I would like to ask you, what do you think about it? And if you got some data from your project about it.
No, that's super interesting. Thank you very much, Valeria. So we haven't looked at autism in our project. So in our project, we analyzed this data that came from actually a different study, a previous study on emergency services for young people who mostly have mood problems. So again, okay, suicide ideation, self-harm, that kind of thing. So the presence there of someone with OCD with potential anorexia is actually quite unusual. Most of the people were presenting with mood problems. And I've also had a little bit of experience, but just kind of talking to people from the Voice Collective. And that, again, is a different type of condition because, you know, what they describe as unusual beliefs or unusual experiences have to do mostly with what we, you know, medics describe as psychotic symptoms. And I have to say the issue of diagnosis, I think, is central to in all of these cases. Yeah. So especially the young people from the Voice Collective, we're saying that the diagnosis becomes a sentence, because maybe they see the practitioner for the first time because of an episode, like a delusional episode, and the word delusion appears in the medical records. And from that moment on, whenever they need support, whenever they go and see practitioners, the word delusion affects everything that happens in the exchange. So if they feel they have a problem with anxiety, the practitioner kind of undermines that suggestion, saying, oh, it must be an effect of your delusion. Or if they express a concern about medication, side effects or something like that, could we try something different because this is affecting my concentration? They say, oh, it's your delusion speaking, it's not you. So they really add this impression that, once that kind of label is there, first of all, it's very difficult to remove it, but even if you don't want to remove it, it affects everything in the interaction. And I think that's potentially difficult. With the people with mood problems, I think the impression was slightly different, because for them, very often the diagnosis is access to support. That's what it means, right? So if they say you've got depression, it's a good thing, because then they can access support. If they don't get that label, they don't get the support. So the diagnosis is seen as something useful. And the researchers with lived experience who worked in the project with us, they said this numerous times: we're not against labeling. We are against premature labeling. So what happens is I show up, they look at me and they say, you must be depressed. And it's like, just listen to me, ask me what's happening to me before you decide. And then, it may be that the decision is the same. But, why haven't we had the conversation first? Why haven't I had a chance to tell you what really worries me? And I think this is actually quite key, and it might apply to the case of autism that you were describing. Sometimes what we are missing is the individual and personal dimension of medicine. It's not about recognizing you as the type of someone who is depressed. It's about trying to understand how depression, or whatever it is, however we want to call it, is affecting you in your life and making things difficult for you. Because unless we kind of focus on that, then it's very difficult to get to a stage where support can be offered that is actually helpful to that individual, right? And that's exactly what we saw in the good interactions. The label was there, but it wasn't center stage. The experiences of the person were more important. The relationships with their parents, with their peers, they were more important, I think. And in the case that you were describing, it also looks like very often we've got premature labeling. We see a girl who's having certain problems. We've heard, cases of eating disorders before. Why not? Maybe that's your problem, without thinking about anything else. And if there isn't this kind of conversation, exploration of what may be going on, it's very difficult to realize, oh, it could be something else. Let's maybe test for it, or let's think about it. So although I don't have any direct experience in that particular field, I think some of the problems may be recurring.
Yeah, thanks a lot. Just a very brief follow-up, because where we were talking, another detail came into my mind. It's something that it makes a lot of sense now, thanks to your talk, and it's something that really did strike me while I was a PhD student, and I did my very first phenomenological interview to an autistic guy. And this guy told me that once he got the diagnosis of high functioning, so-called high functioning autism, he was very happy about it, because suddenly everything made sense for him. And he was telling everybody, so it's outside of the clinical context, but it's very meaningful in my view. He was telling everybody, I am autistic, so this is why, I didn't understand the jokes at school. And he told me, I don't understand why everybody told me, no, don't worry, maybe they are wrong. And he felt unrecognized, So there is also the issue of recognition, also outside of the merely clinical context, but still, so it's another case in my view of epistemic injustice. And he was so worried and so annoyed, because I'm very happy why people do not recognize me, do not believe me, do not want to believe me when I say this.
No, I think this is super important, because very often when I give these kind of talks, or my colleagues do, the reaction is, oh, come on, it's not doctor's fault. Clearly they're doing their best with the resources that they have. It's kind of this epistemic injustice stuff is doctor bashing, right? It's not because this applies to every interaction that these young people are having, right? In the school, in the family, with their friends. It's just that when it happens in the clinic, then it might have repercussions for the kind of health prospects, because they may or may not have access to support that might help them. But that's not to say that it's a problem with the healthcare system. It's a problem with our society and the kind of assumptions that we have, that we associate with those particular behaviors, because sometimes we don't understand the diagnosis very well. Like, I don't understand the ones I'm not studying, for instance. But we have an idea of what it is to be autistic. And, we may be thinking, oh, it's really bad, right? So when people say, and those stereotypes, even if we try to be inclusive, affect the way in which we talk to people, affect the way in which we include them or exclude them in certain particular projects. So for instance, the example that we had in the video, where the university lecturer says, you're having some difficulties. For someone who hears voices, this program is too challenging. This was an experience of one of the young people in the Voice Collective, and it's very common. And the thought is, surely you can think about some support that this person can have. And with that support, it may be less challenging for them. It may be possible for them to achieve it. But there is this connection. If you hear voices, then, maybe you don't perceive reality as it is, or, and that affects every single interaction. So that's very important that you mention this dimension outside the clinic, because otherwise we tend to think, oh, it's a medicine problem. I don't think it's a medicine problem. I think it's everybody's problem.
Thanks a lot. I don't know if there are other questions. Since not, so we can. I also, Caroline.
Yes.
Please.
I'm really, I loved your talk and what you talked about. I'm not I'm not from your subject, so I'm not a psychologist, or psychiatrist, or phenomenologist, but I'm very interested. Also in this method, you said this interaction analysis method with the eye, where the eye are directed to, and so on. Could you tell me again the method that I can do research on that?
Of course. So again, I'm not the expert there. So in the team, we had 2 people who were experts in that methodology, which is conversation analysis. And I'm told that is used a lot in sociology and psychology. Basically what they do, they analyze interactions using the video recording, because that gives you the non-verbal cues. But also using the transcript. And sorry, I'm losing my voice. And the transcript, it's interesting because it tells you how long, for instance, the pauses are, or, what kind of words are used. But sometimes even just the grammar, it really opened my mind when they mentioned it. How you ask the question, if it's a closed question or if it's an open question. And this is so important in like risk assessment, for instance, for suicide, because they said, you're not thinking about killing yourself, right? Who is going to say, no, yes, I'm thinking about it? Almost nobody, right? Because there is this pressure of saying no. But if you ask, okay, so what are your thoughts today? Are your thoughts about death? Are your thoughts about something else? Then, you open up the possibility for the person to explain, right? Whatever it is. And what really struck me is Rose McCabe is amazing. So if you find some lectures by her online, I strongly recommend it. It takes the same amount of time to ask the question, right?
Yes.
It's just the tone of voice, as you were saying, the gaze, that really makes a lot of difference.
Yeah, I know. So I'm an anthropologist. I did conversation analysis.
Oh,
but
okay, sorry.
I think there might be much more to that. Like advanced stuff, or maybe even using like video KI even already to detect time and have patterns, but maybe we are not at this point yet. But I'm trying to explore how far this method is evolved yet. So thank you very much. So I wrote down Rose McKay, yes, as
Rose McCabe, and she's at City University of London. So
Okay.
you'll find her work easily. Yeah.
Thank you very much.
No problem. Thank you for your
I
question.
appreciate your work. Wonderful.
Thank you very much.
Okay, we have other questions. Since we don't have further questions, so I thank you again. Thanks a lot for the wonderful talk.
It was a pleasure. Thank you for inviting me.
Yeah, and we really hope to see you in the next future.
Yeah, of course. Thank you so much.
Thanks,
you for
everybody,
listening.
and see you soon.
Thank you. Thank you for
Bye-bye.
organizing.
Bye-bye.
Bye-bye. Bye.